Tokyolive Endoscopy 1.
So, hello everyone, welcome to Tokyolive Endoscopy 1. I'm Haru Inoue, Showa University Koto Hospital. Topic of this session is approaches to upper GI bleeding. It's my great honor to introduce my co-moderator, Dr. Min-Chi Ho. He is professor of Taipei Veteran General Hospital and the current president of the Taiwan Society of Endoscopy. And today we have two distinguished speakers. So I would like to introduce the first speaker. So first speaker is the Professor Ian Graunek. He's a professor of medicine, IMEC Medical Center, Israel. And he spent many years in UCLA. And today he will talk about the upper GI bleeding. It's a very important and clinical, basic, but the practical topic for us. So Ian, so please start your lecture.
Thank you, Professor Inoue. I want to thank you very much for this kind invitation to be here as part of Tokyolive and the other organizers. It is truly my honor to be a part of this conference. I'm going to share my screen with everybody. Okay, I believe everybody can see this. So I have been tasked here to give a talk on endoscopic management of acute non-variceal upper GI bleeding. These are my competing interest disclosures. This is a pretty typical case of what we see today when patients come in with acute upper GI bleeding. This case actually happened just about 2 weeks ago. This is a patient who's 78 years old. He came into our emergency department with 3 episodes of melena over the past 24 hours and also had near syncope at home. He has a history of coronary artery disease and had a coronary stent placed, 2 stents placed 4 months ago. And he's been using dual antiplatelet therapy since then. So he's taking Plavix and aspirin. He's also on a statin and a beta blocker. He recently, however, has been using NSAIDs because he's been having low back pain with sciatica. In the emergency department lying down, he has a heart rate of 107 and a blood pressure of 99 systolic. And then when he was sat up, his heart rate went up to 121 and his blood pressure dropped to 78, his systolic dropped. So he had evidence of orthostatic hypotension in the emergency department. His initial hemoglobin was 11.7. His baseline hemoglobin had been about 14. So really the correct approach and how we really should think about these types of patients who present like this to the emergency department is to think about what should we be doing prior to doing endoscopy. What do I need to do once I've diagnosed the cause of the bleeding? What do I do endoscopically? And then lastly, when I'm done with endoscopy, how do I treat these patients after endoscopy? Now, I'm really going to focus mainly on endoscopic management. I'm going to say about a minute briefly about pre and post endoscopy, just so we're complete here. Now, this is the guideline that was just published by the European Society of Gastrointestinal Endoscopy 3 months ago in March, where I was the lead author on this. This is an update to the guideline on non-variceal upper GI bleeding that we published in 2015. So what do we think about pre-endoscopy? We should be thinking about these types of patients in the emergency department about hemodynamically resuscitating these patients initially with crystalloid fluids. We routinely should not be placing nasogastric tubes. This is no longer recommended routinely, but only in selected patients. We should be thinking about what we can do with antithrombotic management, as well as risk stratifying patients using the Glasgow-Blatchford score. We can think about giving pre-endoscopy IV PPI in these patients because there's data to show that that may reduce the severity or the stigmata of bleeding at the time of endoscopy. We should be using today or adapting today what's called a restricted blood transfusion policy. In terms of antithrombotic management, like in this patient, We need to be making sure that in this type of a patient on dual antiplatelet therapy that they can have their Plavix held, but they should continue on their aspirin. If they're using anticoagulants, we also need to temporarily hold them. I'm not going to get into the details. You can look at this in the guidelines, the specifics of all these pre-endoscopy management recommendations. Lastly, we can consider using a promotility agent to clear the stomach if we think there is blood or clots prior to performing endoscopy using IV erythromycin. And lastly, the current recommendations are really to be endoscoping these types of patients who are suspected to have non-variceal bleeding. We should be endoscoping them within 24 hours of the time that they present to the emergency department. Now, what about endoscopic management? And this is really based upon recent references, including ours from the European Society, as well as an international consensus published in 2019, and also the American College of Gastroenterology that was just published last month in May. So we all should be fully aware that, and this is really going to mainly focus on high-risk stigmata from peptic ulcer bleeding. So patients who have high-risk stigmata, including Forest 1As and 1Bs, so spurting ulcers or oozing vessels, these types of patients need to be treated endoscopically, as well as patients who have Forest 2A lesions, so non-bleeding visible vessels like we see here. These patients need to receive endoscopic therapy. So we have a number of tools in our toolbox in 2021. We have injectables that we can use using a needle. We have now a variety of through the scope hemoclips that can be used in these patients. We have contact thermal probes such as a gold probe. We also have argon plasma coagulation. We now also have over the scope clips such as the Ovesco clips that we're seeing more and more are being used in these types of patients. We have rescue therapies such as hemospray. And we also now, there are some emerging data looking at even at bipolar coag graspers in the treatment of non-variceal upper GI bleeding. So what is currently recommended? So specifically in patients who have Forest 1As or Forest 1B ulcers, so spurting or pulsatile arterial bleeding or oozing, we should be using today what's called combination therapy. Combination therapy here is defined as we should initially be pre-injecting with dilute epinephrine, it's generally 1 to 10,000 concentration, that we can inject around the 4 quadrants of the bleeding ulcer. But then we combine that with an additional therapy. And that therapy can either be mechanical therapy, where you can use a through the scope clip, or even a cap mounted clip, like an Ovesco over the scope clip. Or if you want to combine the epinephrine with contact thermal therapy, such as a bipolar probe or even a heater probe. So now this is a video. It's a nice demonstration of combination therapy. This is an antral ulcer, which I think we can all see. This is a Forest 1A. This is actively spurting. There's a small little ulcer, but there's also a small vessel there that is actively bleeding. So this would call, based upon current recommendations, we would want to do combination therapy, ideally, to this lesion, okay? So what can we do? What we first want to do is we can take an injector needle and we can inject around the ulcer with dilute epinephrine. And what that's going to do is basically cause a tamponade effect. And it actually will probably cause some vasoconstriction locally. And that should either slow down the bleeding or potentially stop it temporarily. Now, you don't want to just use epinephrine because that's inadequate for durable therapy. So we've now injected, it's slowed down, it's still a little bit oozing here, but what we're going to do is now we're going to take a through the scope hemoclip, and we're going to clip that vessel closed right over that area that we just injected, okay? Probably you can put another 1 or 2 there, but this is pretty much closed that bleeding site, and this is considered to be adequate therapy and what's recommended in these types of patients. Now, what if you want to use thermal therapy instead? This is an older video, but it's a good demonstration. So this is an actively spurting, again, a 1A Forest lesion. This is a gastric ulcer that's actively spurting. And what we can do here is we're going to, again, inject initially with dilute epinephrine to try and slow down that spurting. You can inject around this area in 4 quadrants, and you're going to see that the bleeding is going to slow down. It's not going to stop completely, but this does give a very nice tamponade effect. And then what we're going to do, we're actually going to take a large 10 French size bipolar probe. This is a gold probe, and we're going to push on this area and use coaptive coagulation, just like we're welding a vessel closed. And we're going to close this vessel using the heat and the desiccation of that vessel using the contact thermal probe. So you see we're pushing on this area and the bleeding has stopped, and we're left with this post-hemostasis footprint in this area. Now, you can also consider in these types of patients, this is what's done here. This is actually an over-the-scope clip. This is an Ovesco over-the-scope clip. Now you see here again, there's a antral ulceration, that's pulsatile bleeding here. This was not pre-injected because we thought that we could do it without. But we're going to actually take the over-the-scope clip. We're going to go right up to this area, sort of like a band ligating device. And we're going to suction this area that's bleeding right into this clear cap. And then we're going to deploy this very large clip over this area. And you're going to see that this clip actually grasps a large area of tissue, and it mechanically closes that bleeding vessel. This works very nicely. And these clips come in a variety of sizes, and there is now emerging randomized controlled data that shows, in 2 studies at least, that these over-the-scope clips can be very effective in peptic ulcer bleeding. What about Forest 2A lesions? And so non-bleeding visible vessels, you see an ulcer here. There's this pigmented protuberance here. So this is a vessel that is coming out of the ulcer base and needs to be treated endoscopically. You can actually pre-inject this area with dilute epinephrine, just like we did with the Forest 1As, or you can just use therapy alone, either using mechanical therapy or a contact thermal probe like what I'm showing here. This is coaptive coagulation, where we're going to push down on this area. We're going to give electrocoagulation, and we're going to burn and close this vessel. You're going to see here, this is what it should look like after we're done giving endoscopic hemostasis. You need to be careful. This is a video. You see there is a non-bleeding visible vessel here. A colleague of mine was doing this. They did not pre-inject with epinephrine. They touched that vessel, and you see what happened. This caused torrential bleeding, active spurting, as you can see here. It slowed down a little bit here. We actually ended up pre-injecting this again, or I should say injecting afterwards, with dilute epinephrine to get it slowed down. And then we're going to take out, it's still bleeding a little bit here. It's active pulsatile bleeding, as you can see. But we're going to take a large 10 French gold probe. We're going to push over this area. We're going to give electrocoagulation, push down, and it's going to stop this from bleeding. So generally, although there's no great data to support this, I usually, in non-bleeding visible vessels, I will pre-inject the area with dilute epinephrine to try and prevent this type of thing from happening. But if it does, you can inject more epinephrine, and then you can use either a thermal contact probe or mechanical therapy using either a through-the-scope clip or an over-the-scope clip to close this area. You see what we did? We managed to get this stopped, and this is what it looked at the end. And this patient was put on a high-dose IV PPIs afterwards and did well. What do we do about adherent clots? These are a little bit tricky. This is a Forest 2B lesion because there's really no consensus to what to do in these types of patients. Do I take the clot off? Do I treat what's under it? Or do I leave this here and put them on high-dose PPIs? My recommendation is that if you feel comfortable treating these types of patients endoscopically, you can go ahead and remove the clot and treat the stigmata that's underneath. So let me show you a video here. This is actually, before I show you the video, this is actually this is from our guideline from 2015. This has not changed with the update in 2021. So if you feel comfortable, you can take the clot off. If you don't feel comfortable playing with that clot, you can put the patient on high-dose IV PPI, and hopefully that will stabilize and the patient will not rebleed. This is, as everybody can see here, this is a very large, deep antral ulceration. And we can all see here that there is a non-bleeding clot. Most of the time, these are going to overlie some type of a lesion. Usually a vessel is underneath there. So what you can do in step 1, if you're going to treat this, You can inject again around here with dilute epinephrine, 1 to 10,000. You can inject 1 to 2 cc's per injection. And again, that's going to give local tamponade and vasoconstriction. And it may prevent this from bleeding when you go to take the clot off. And I say maybe, because you'll see what's going to happen here. But we're pre-injecting around this area with dilute epinephrine. You don't inject into the vessel, you inject around the area here. Okay, so we're injecting. And now what you can do is you can either try and suction that clot off, or you can use a small polyp mini snare to try and take off the clot. Now this was tried to be suctioned, and even with suctioning, this started to actively bleed. You see this one little spot here, there's a vessel here that's actively bleeding. We've now taken off that clot with suction. We're washing away that active bleeding here. You could potentially re-inject with epinephrine, but if it's comfortable, you can either treat this here with a thermal contact gold probe like what's doing here, or you can treat it with clips, either a through the scope clip or an over the scope clip. Now in this situation, because this was a very large fibrotic ulcer, we decided to use a contact thermal probe. My other recommendation here, this was done really before Ovesco, is that you could use, because this is a large fibrotic ulcer and through the scope clips can be very difficult to treat here, you could consider using an over the scope clip to try and treat this, this bleeding area. What do we do if there's persistent bleeding? What happens if I can't get the bleeding stopped? What are the rescue therapies that I have available today? Well, you have topical sprays and powders like hemospray. We have mechanical therapy, so over the scope clips can be used as rescue. And then also we can use, as I've talked about earlier, coag graspers for thermal therapy. And these are still considered rescue therapies as of today. So if you have persistent bleeding you can't get stopped, if you're going to use a topical agent like what is being used here, you need to have active bleeding. You need to have active oozing or some type of active bleeding for these powders to be effective. You want to make sure that you're, to stop the catheter from being clogged, you want to dry your working channel before you put the catheter through. You want to make sure you disconnect the suction so you don't suction water to clog the catheter. If it does get clogged, you can take out the catheter and clip the end off and it can open up and you can start to use that again. You also want to make sure that you extend out the catheter far enough so when you deliver the powder, it doesn't come back at you like a snowstorm and obscure your field of view. Generally, what we will do in these types of cases, if we use hemospray, we will treat them, and then we usually go back 24 hours later to relook as long as they've been stable and make sure that everything's fine. Now, this is an interesting case I'm also going to show you where an Ovesco over the scope clip was used as rescue therapy. What you're going to see here, this is a very large duodenal ulcer. This is a video that was given to me by Marine Camus from Paris. And you can see here that she had tried, this is a very fibrotic ulcer. And you can see here she tried to use through the scope clips, but through the scope clips were not adequate. This continued to bleed. You can see the clips here. So she's trying to inject more epinephrine, but it continues to bleed. And what she decides to do actually here is to use an over the scope clip. I'm just going to try and show you some of this video. This is her loading the over the scope clip onto the gastroscope. This is very similar to a band ligating device mechanism that we use for treating varices. So you put the device through the working channel, and then what you're going to do, just like with a band ligating device, there's a clear cap with this nitinol clip that sits on the end of it. And you're going to pull it through the scope, and you're going to fasten this plastic cap onto the tip of the endoscope, which you see right here. Then you're going to go back down. We'll move this ahead. We're going to put this back into the patient. And now the clip is on here. We're going to suction this area that's actively bleeding into the clear housing, just like band ligation. And you're going to be able to, she was able to deploy this nitinol clip over to the bleeding site. She's going to do this momentarily. And the bleeding was stopped. And you'll see now she's deployed it. You see the clip now is grabbing a large amount of tissue here. You'll see it here in just a second, even better. And here it is. So this is this very large fibrotic ulcer. The bleeding has stopped, and this patient did well after using the over-the-scope clip. Okay, one last video. This is another case that was actively bleeding, and where a coag grasper was used. It's almost looks like it's in a large ulcer base, but there's one little point of bleeding here, and it was decided just to use a coag grasper. This area is grabbed. It's tented slightly, and coagulation is delivered, soft coagulation, and it stopped the bleeding here. There's been a few papers using coag graspers, and I think we're going to see more of this used in peptic ulcer bleeding. Do not use epinephrine alone, as I've said. It's inadequate for long-term endoscopic therapy. My final tips is really in these types of patients, we should be using a large single channel or double channel gastroscope. We need to have water jet capability for washing the area. If you're going to use contact thermal therapy, you really should use a large 10 French probe, and that's why we should be using a large therapeutic gastroscope. For large fibrotic ulcers, I think we're really moving to over-the-scope clips to be used. For rescue therapy, you can use a topical agent or powder or over-the-scope clip. And I really think today in 2021, we need 24/7 coverage and nurse coverage for these types of GI bleeding cases. Post endoscopy, we need to give high-dose IV PPIs in these patients. You can initiate clear liquids. If this is from peptic ulcer bleeding, remember to test and treat for Helicobacter pylori. We want to make sure that if they're using antithrombotics, that we're putting back on their antiplatelet agents or their anticoagulants. We don't want to treat their GI bleeding, then have them have a significant cardiovascular or neurovascular event because they have not been restarted on their antithrombotics. If they have clinical evidence of rebleeding, we should rescope them and retreat them endoscopically if necessary. If endoscopy is not working, these patients today really should be sent to interventional radiology for angiography and potentially transcatheter angiographic embolization if you have interventional radiology at your center. Lastly, surgery is really rarely needed today in these types of patients. We've moved on. The second step, if endoscopy is not working, is really for these patients to be sent to interventional radiology. What's the future? I think the future is we're going to see more increased use of cap-mounted or over-the-scope clips. We're going to see more topical agents and powders and gels that are going to come to the market. I think we are going to see larger and stronger through-the-scope clips. And I also think we're going to see increased use of hemostatic forceps. And with that, I'm going to stop here. I want to thank everybody for their attention. I would like to thank Professor Inouye for the invitation, and I'll be happy to answer any questions. Thank you.
So thank you very much, Ian. So it's a really great lecture and really educational. And you mentioned in your lecture that the step-up treatment, starting from injection, and then reduce the speed of the bleeding, and then after that, so replace the clip, and then, so if necessary, we will use the Ovesco, and then so yeah, such kind of step up, yeah.
There's data. There's data from the STING trial that showed the use of Ovesco for recurrent bleeding. That was published in Gastroenterology, I believe, in 2018 or 2019. There is a recent study, I think it's now out, from Dean Jensen and the UCLA group that actually looked at upfront the use of Ovesco over the scope clipping, and the analysis was a little bit difficult to decipher, but it actually showed that there was advantages of using an over-the-scope clip. And that's why I think that, especially for these large fibrotic ulcers, I really think that the through-the-scope clips, it can be oftentimes very difficult to use them because they're just not strong enough with the fibrotic ulcers, whereas the over-the-scope clips can be very effective in those situations.
And you introduce us the usage of a powder for recurrent of the bleeding case powder.
For the powder.
We recommend it.
Yeah, so for powder, really, I really would use powder if I'm really trying, let's say, combination therapy with standard therapies. and it's just not working, I think your options there are either to try and, if you don't feel comfortable using an over-the-scope clip, and not everybody does, if you have powder available, it's very easy to use, and it can actually stop the acute bleeding. And then you can go back 24 hours later and reevaluate the area. I think for those patients who are just not responding to standard endoscopic therapy, if you feel comfortable using an over-the-scope clip, I would go to that, because to me, it's more definitive than using powder.
Okay, so do you accept this kind of concept? So the patient coming in the midnight, and then a resident novice endoscopist stay in the hospital. So he never used Ovesco and some other therapeutic, so he don't have the right skillful endoscopic technique. So at the time, he don't have the technique. So at the time, so he may use the powder to control the bleeding temporarily. The waiting for the expert coming to the hospital. Is it okay?
Yes. Yeah, I think that that's fine. I think that's actually a good situation, but I'll take it one step further, Professor, in a way. There's now, if you look at the paper from James Lau from Hong Kong that was in New England Journal a year ago, we're moving away where we really, it's rare now today, in my opinion, that we really need to be endoscoping these patients between midnight and 6 in the morning. There's data to show that if we endoscope patients too quickly and they're not fully hemodynamically resuscitated, we actually may be doing harm to patients. The current recommendations, and this is from our updated guidelines, is most patients can be scoped within 24 hours from the time they start, when they come into the emergency department. They need to be stabilized. They need to be given IV fluids. They can be given IV PPIs. So, but if there is a need to do something in the middle of the night like that, and you have a junior person on, it's fine to use powder if they don't feel comfortable using other therapies.
And one more question to you. So if the patient has the full stomach, suspected full stomach at the time, so how do you manage the patient? So selection of the scope and the do you use an overtube on it, or?
So what we'll do is, if we suspect that the patient still has blood in their stomach or clots in their stomach, generally what we do is we will give 250 milligrams of IV erythromycin. It's a promotility agent, and we will give that anywhere from 1 to 2 hours before we're going to do the endoscopy. So it's just one time. As long as there's only a couple contraindications to erythromycin. If they have an allergy to erythromycin, you can't give it. If they have a known prolonged QT interval, that's also a contraindication. In those patients, you can try and give those patients Pramine, another agent, but the vast majority of patients can get IV erythromycin. Within 1 to 2 hours, the stomach is cleared, and you're able to have a clean stomach, and you can see.
So you do not recommend the usage of the overtube if there is a huge bleeding? So
no, I wouldn't use an overtube. What I would do in patients who are having ongoing active hematemesis, and we may hear this from the next speaker about variceal bleeding, patients who may have a hepatic encephalopathy and cannot control their airway, then I would prophylactically intubate them, endotracheally intubate them, to protect the airway. I would say that maybe happens with non-variceal bleeders maybe 10% of the time, okay? So it's really, if we're very worried about protecting their airway, I wouldn't use an overtube. I would actually endotracheally intubate them and protect the airway.
So intubation is by the anesthesiologist or by yourself?
Yes. No, we have the anesthesiologist come and do that. Yeah.
Okay. Thank you very much. So any other question or comment?
I have a question. I'm in Jiho at Taipei. I have a question for the Professor Granek. For rescue therapy of the persistent bleeding, do you think injection of glue, the cyanoacrylate, is useful in this situation?
It's a good question. There's been some data. There's certainly not been any randomized trial data looking at cyanoacrylate glue. You could try it. I have no personal experience. There have been some case series that have looked at that. So my short answer to you is I think if you have experience using cyanoacrylate glue and you feel comfortable, you can try it. Because there has been some reports that it can be effective, but it's certainly not recommended at this point in guidelines because there's just not enough data.
Okay, thank you.
Okay,
Thank you.
so thank you very much. So we will discuss later again, and we'd like to move on to the next speaker. So Dr. Min-Chi Ho, please introduce the next speaker.
Okay. Dear colleague, Professor in Norway, Professor Glenneck, and Professor Arisawa, I'm Min-Chi Ho at Taipei. It's my great honor to join Tokyolive 2021, and also my great privilege to introduce our next speaker, Atsushi Arisawa. Professor Arisawa graduated from Tokyo Medical University in 1989 and obtained his medical doctorate degree from Fukushima Medical University in 1996. He was a vice faculty of EUS Center in University of Florida. From 2010, he was a professor and the director of Department Gastroenterology, Ezu Medical Center, Fukushima Medical University. Since 2018, he moved to Tokyo Medical University as a professor and chairman of Department Gastroenterology. His specialty is mainly endoscopic diagnosis and treatment for pancreatic biliary area, particularly in interventional EUS and ERCP. Also, he is a specialist in the field of portal hypertension. Let's welcome Professor Atsushi Arisawa to give us a talk entitled Endoscopic Management of Esophageal Gastric Viruses Bleeding. Please, let's welcome Professor Arisawa.
Thank you, Professor Ho. Thank you for your kind introduction to me. So it's my great honor to be here. Thank you for the President, Professor Inoue, and Chairman, Professor Ho, for giving this opportunity. My topic is endoscopic management for esophageal gastric varices bleeding. So I will talk about including management after hemostasis. So first topic is endoscopic treatment for esophageal varices. So in overall epidemiology, so about 40% to 95% of patients with liver cirrhosis have esophageal varices. Although 15% to 20% of esophageal varices bleed within about 1 to 3 years after diagnosis. So several different treatments are available, including endoscopic scale therapy and variceal band ligation and something else. For the management of the hemorrhage from the esophageal varices, we have two endoscopic therapies, band ligation and sclerotherapy. So generally, the difficulty of the procedure is lower in banding than in sclerotherapy. So therefore, banding is often performed for the esophageal variceal bleeding. So previous literatures have shown the superiority of band ligation over the sclerotherapy for treatment of esophageal variceal bleeding. I briefly introduce some literatures. So the first one is from the Professor Stigman, who is developed the band ligation. So Professor Stigman shows slightly more sclerotherapy treated patients had recurrent hemorrhage in comparison with band ligation. And also, Professor Ho shows active bleeding was controlled with ligation as efficiently as with sclerotherapy, and the rebleeding rate was lower with band ligation. And a recent report shows the rebleeding rate in actively bleeding varicella patient in the banding group was significantly lower than that in the sclerotherapy group. So the ligation is the first choice for treatment of bleeding esophageal varices. And with sclerotherapy being an alternative, if ligation is not available or technically not feasible. So banding very easy. So, but sometimes it is difficult, just difficult because bleeding impairs visibility. I show the video. The band ligation for the esophageal varicella hemorrhage. Here you can see the spotting bleeding from the esophageal varices here. So the field of vision is poor due to bleeding. So after identify the bleeding point family, so we perform the EV band ligation. So performing ligation is very difficult, but this is very useful with our experience, my experience and hunch. So as I have talked about, banding is good as a first treatment for bleeding. But in the case of banding, and the recurrence over a long period of time is still problem. So this recent report showed that banding plus sclerotherapy has a lower bleeding recurrence rate. I think this is because adding sclerotherapy after hemostasis can provide a wide range of thrombosis, including the varicella feeders. So from this point of view, performing sclerotherapy after hemostasis may be important choice considering the long-term prognosis. Here you can see this figure. So this is sclerotherapy under fluoro. So this is varices, and this is a fetus. So endoscopic injection sclerotherapy will be obliterate not only varices, but also fetus. So I show the sclerotherapy for esophageal varices. So this is after initial treatment for bleeding. So you can see the video, sclerosant with contrast medium injected into not only esophageal varices, but also feeders here. This is feeder. So in my opinion, this is very important procedure to prevent the recurrence. So in addition, it is worry about emboli of the other vessels, but this technique is safe because of performing under fluoroscopy. So by the way, for hemorrhagic esophageal varices, depending on the facility, it may observe by only medication, such as somatostatin or vasopressin or beta blocker, something else. Although the usefulness of drugs, which reduce portal pressure, has been reported. Endoscopic treatment should be performed firmly for bleeding cases. So this systematic review showed medication alone had a higher mortality than sclerotherapy. On the other hand, in order to prevent rebleeding, it is highly used to additional medication during endoscopic treatment. So we should understand this evidence. Okay, I will move to next topic. Next topic is for gastric varices. So generally, gastric varices are seen in about 15 to 20% of patients with portal hypertension, and they are responsible for only 10 to 30% of cases of variceal hemorrhage. However, once bleeding from the gastric varices, there is a serious and life-threatening event. The endoscopic criteria, such as the size of largest barracks and the presence of red spot, so provide the most essential information for predicting a hemorrhage from the gastric varices. So therefore, hemorrhagic gastric varices must be treated quickly and reliably. Moreover, if the gastric varices have some risky findings of bleeding, prophylactic treatment should be performed. I introduced one systematic review regarding hemorrhagic gastric varices. So you can see this analysis. So it is indicated sinus injection is superior to sclerosant injection or banding in control of bleeding and preventing of rebleeding. So endoscopic therapy with sinus is considered the best hemostasis with a long risk of rebleeding compared with other endoscopic method. I will show the video. You can see the sinus injection to the hemorrhagic gastric varices. Now, sinus was injected into the varices. So we can confirm injected sinus under fluoroscopy. Usually, with the sinus used sinus is combined with contrast medium. So after remove the needle from the varices, so hemorrhage is stopped. So after initial hemostasis, we have to consider the additional treatment to prevent the rebleeding. So I show the two literatures. These two literatures showed additional interventional radiology, such as TIPS or BRTO, is useful for prevention of rebleeding. So why is it difficult to prevent rebleeding with endoscopic sinus injection alone? So you can see the hemodynamics of the gastric varices on this 3D CT. So here you can see the varices here. And these varices provided the blood flow from the fetus short gastric vein. And the drainage route is gastrorenal shunt here. Therefore, to eradicate the gastric varices, in my opinion, we need to obliterate not only varices, but also feeding vein. So the past literature, it is difficult to obliterate the feeding vein using endoscopic treatment. But we are endoscopists, so we would like to perform the additional endoscopic therapy to prevent rebleeding. So recently, ES guided coil therapy was developed. So EUS coil therapy has high clinical success rates with low risk of adverse events and a low rate of rebleeding, particularly when compared to endoscopic sinus injection. So deployed coils completely blocks blood flow of gastric varices without leak to the major circulation. So because the diameter of used coil is larger than variceal diameter. In addition, because this technique is performed by US guidance. So it is more reliable endoscopic treatment. However, when the only coil deployment was performed here, so feeder may be remained. So therefore, it is needed eradication, not only varices, but also feeders to prevent recurrent. So this paper shows combined therapy, coils, and sinus injection. The author shows good results. Rebleeding from obliterated gastric varices occurred in just only 3%. So additional sinus could be obliterated the remaining variceal lumen and feeders. So in same point of view, we developed the therapeutic approach using sclerosant. At first, coil deployed into the gastric varices. And deployed coils just move to the drainage vein side. And then coils completely block the variceal blood flow. Next, injected sclerosant obliterates the remaining variceal lumen and feeding vein here. So this technique can eradicate naturally gastric varices, but also feeding vein, I think. I will show the case. You can see the huge gastric varices with feeders, short gastric vein here. So you can see the video. At first, I measure the diameter of the gastric varices. And using the 19-gauge needle for ESFNA. So I puncture the gastric varices from the esophageal wall. And next, suction, you can see the blood suction. And first, injection of the contrast medium into the gastric varices under fluoro. So under fluoro, there is no image. So because of fast, very fast blood flow of the gastric varices. So and then we push the coil into the gastric varices using stylet here. So here you can see the deployment of the coil into the gastric varices. So this is a US image, so coil deployment, and this is a fluoro image, coil deployment. After the deployment of first coil, so we injected the contrast medium again under fluoro, but there is no image. So the remaining, because of remaining the gastric variceal blood flow. So next, we decide to deploy the coil here. So after a second coil deployment, so injected into the gastric varices using contrast medium. So you can see the contrast medium stay in the gastric varices and feeders. So next, we inject the sclerosant into the gastric varices and feeders. So you can see that there is no variceal blood flow after coiling and sclerotherapy. So the image show before and after treatment. After treatment, on 3D CT, the disappearance of the gastric varices. You can see the just coils. We achieved completely eradication of gastric varices and feeders. So, ladies and gentlemen, in my conclusion, endoscopic treatment is useful for hemorrhagic esophagogastric varices. To prevent rebleeding, appropriate additional treatment is required with understanding of variceal hemodynamics. Thank you for your kind attention.
Thank for Professor Arisawa, excellent speech and a very nice video. You give us a very practical management of acute gastroesophageal bleeding.
Thank you.
I would like to have some question for you.
Yep.
You have not mentioned about the hemostatic powder, hemospray.
Yeah.
Do you think hemospray have any role in the management of the varus bleeding?
I'm sorry, I have no experience for the powder for the gastric variceal or esophageal variceal bleeding. I'm sorry.
Okay.
So, but variceal bleeding is usually spotting bleeding, very spotting bleeding. So I think the powder is not workable.
Yeah. Yes, just a recent publication. Use of hemospray can improve the later endoscopic treatment. Yeah. Also, I would like to have another question for you. I know you are a US expert and do many hemodynamic study of esophageal varices. Hemodynamic study. I think it is very good for US guide coil, maybe mixed with sclerostin or glue. Do you think I have no such I have no many experience in this US guide. I just want to know US guide treatment is can be applied in every kind of situation, like active bleeding or mass bleeding. Is that useful at this moment? US guide is feasible?
Yes. If the patient have a gastric variceal bleeding, so at first I perform the glue injection, and next I using US guidance treatment.
Okay.
So, Irisao Sensei, you mean the US guided coiling is the elective method?
Yes, elective.
Avoid
yes.
Recurrent bleeding. Okay.
Yes, of course.
Understand. Yeah.
Okay. I know in Taiwan, actually, because of the superiority of the ligation, we have no sclerosis available in Taiwan because it become more expensive because of the rare use. Do you suggest any kind of the other kind of the sclerostin can be used in just in replacement of the Erythromycin or Sotradeco, such like alcohol.
Alcohol, yes. Yes, alcohol is very useful, but usually we use SRM to obliterate feeders about 7 or 10 milliliter. So if we use 10 milliliter of alcohol, so it's very dangerous to the patient. Yes, I think.
Okay. I have the last question. For the patient with persistent bleeding or refractory bleeding to endoscopic treatment, what is the opinions or your suggestion about esophageal stenting?
Oh, yes. I have never experienced of the esophageal stenting, but sometimes we perform the Sengstaken Blakemore tube, so with balloon. So using balloon after hemostasis, next we try to endoscopic treatment. Yes, but esophageal stenting is very interesting to me. Yes.
Okay, thank you. Actually, I know that BRTO is a very effective method to treat gastric virus spreading. It also in Japan, I think it's very you are I mean you are the pioneer in performing BRTO, but then it is out of the scope to date endoscopic the road. Okay, is there other question? Professor Inoue, do you have any other comment?
Yeah. So I'm so interested in endoscopic coiling.
Thank you.
It's so good, so great. So we watched the many BLTO and the radiological interventions, but it's my first time, honestly, to see the which is US guided coiling, combined with the sclerosant. So thank you very much.
Thank you.
Good to know.
Yeah.
Okay.
But just the skillful hand.
Okay. Okay. So I think the time is about it up. I believe through the lecture and through the thorough discussion, we have updated our knowledge and the skill for management of the upper GI bleeding, comprising of varicose and non-varicose bleeding, from Professor Granley and Professor Ayasawa. And I know that you and me are trying very hard to get rid of COVID-19. I hope we can attend Tokyolive face-to-face soon in 2022. See you.